Hello, everyone. I'm John Lind, the founder and chief editor at Healthcare IT Today. We're excited to bring you another in our series of interviews with top leaders in healthcare IT. And today, we're talking about a really challenging topic that's healthcare harm and medical malpractice. And our guest is Stephan Landsman. He's co-author of Closing Death's Door: Legal Innovations to End the Epidemic of Healthcare Harm. Welcome, Stephan.
Well, John, thank you very much. I appreciate you asking me to come on the show.
Yeah, well, I'm excited to learn. I mean, this is an area I'm not an expert on, but also scares all of us in health IT. So I'm glad you're going to share some insight. But before we dive into your book and all that, tell us a little bit about yourself and your new book.
Well, I've been a law professor for a very, very long time, since late 1970s. Before that, I was a practicing lawyer, and I have handled a number of healthcare-related kinds of litigations, including some things in the Supreme Court of the United States, and thought that this was a topic that, from my experience, has not been effectively discussed and has not been effectively managed. So it seemed like a place to focus and do some thinking.
Yeah. And I want to get into the technology aspects and even telehealth aspects of this. But before we get to the kind of tech side of things, how effective really has medical malpractice laws been at preventing medical harm? I mean, I think that's the intent, right? This medical malpractice is trying to prevent harm. Has it been effective? And what's kind of your experience?
It's been an absolute disaster. And I think that, most candid analysis would suggest exactly that. We have more than 400,000 Americans dying every year because of medical errors in hospitals. That doesn't include surgery centers and other freestanding kinds of clinics and so forth and so on. 400,000 Americans a year. And that's a pretty consistent kind of number. Not necessarily the 400,000, but the percentage of the population, the percentage of the patient population. And, we've known about this for a very long time. In 1999, the Institute of Medicine of the United States said, look, we have a terrible problem with medical error causing the death of patients. And we have not gotten better. We have not improved it. So that was a roundabout way of saying, well, how about medical malpractice? It doesn't do the job. And what limited impact it had, and it was some impact, especially sometime in the past, has been watered down by further legislative restrictions over the last 20 years or so. So that you are simply not seeing a mechanism that is encouraging sufficient safety in the delivery of medical care.
And why is this? I mean, to me, it kind of maybe feels like these privacy laws, when you hit a privacy law against like a social network and then they get fined, $100 million or $1 billion. And they're like, okay, that's just the cost of doing business. Is that what's happening with kind of medical malpractice? Is doctors are like, it's just the cost of doing business now, or is there something more to it?
I think that that's a really tough question to answer. I think that there are lots of moving parts here. Yeah. Part is the way medical care grew up in the United States, this sort of balkanized, disorganized, disconnected kind of approach to the problem of healthcare. Beyond that, I think that the practice of medicine has, since at least the turn of the into the 20th century, 1900 and further, has emphasized the independence of the medical practitioner. That oversight has been fought at every level all the time. If no one's looking over your shoulder, if no one's saying, hey, you got to do better, then you're oftentimes simply not going to do it. Medical care has emphasized in the United States innovation. We have been the most innovative. We have been the most energetic. We have been the most effective at new treatments, at new medications. But at the same time, the risks have increased. And we haven't imposed a level of care to take care of those risks.
So when you look at the technology that's been implemented in healthcare from a malpractice perspective, has the technology helped or hurt the situation?
I think both. That, quite candidly, some things have been a real improvement. I mean, we do better on a lot of fronts than we ever did. Just think about things like penicillin. I mean, we're talking about 1940s or even a little earlier than that, and that was a miraculous turn away from the kinds of infection kinds of things that killed so many people. And, our approaches to some of the transmissible diseases, I mean, whether it's mumps or chickenpox or measles or any of that stuff, polio, we've done great stuff. That's at least in part technology driven, although it's also healthcare related. I mean, public healthcare related.
It's a mix.
And, all that stuff has been great. On the other hand, we have created very powerful pharmacological responses. And some of those responses have, sort of endangered Americans. Now, let's go to the outlier, opioids. Just think about what opioids did. We really wanted to address pain, a very serious matter for many, many, many Americans. But what we did was we commercialized it, we flooded the markets with these medications, and now we have an opioid epidemic. I mean, that tells you both sides of the story, and you've got to be better on the regulation side to get the benefits without the harms.
Well, and I think taking it a step further, you have a chapter in your book about information technology and how that's changed, in a lot of ways. I'd love to hear some thoughts on the information technology side. One that stood out for me from the book was you talk about when they allowed for a at-home pregnancy test. And just the impact of that and how it was fought at every area, right? Like patients shouldn't be trusted with this. You can't allow them to do it. What if they, whatever. And we're having that same discussion today in information technology, as now we're pushing home tests, whether it's COVID tests, which is the popular one today, right? But lots of, ECGs at home, the watches are measuring everything. Like now that discussion is on steroids. So I'd love to hear any thoughts there.
Well, it's that same push and pull that, let's begin by saying some of this stuff is just great. That bringing to the patient the ability for early information about a problem and being able to do it on your own and to be able to do it without extensive cost and time commitment and, sort of reliance on others, just terrific. My sister has type 1 diabetes. The technology moving to make that a less life-threatening kind of experience is certainly just dramatically terrific. And when we can put power and information in the hands of patients, we get a real positive result. Now, having said all that, lots of people don't do it very well. Lots of people are not effective in taking, part in their own treatment. Now, I think that we've overestimated that, and we've left too much in the hands of professionals. Your reading of our book on the topic of home pregnancy tests is that kind of situation. Women couldn't handle the information. They wouldn't be responsible. They wouldn't go to doctors. Baloney. It wasn't that way. But
we've proven that's not true.
But it's a change in attitude, and it's also, what is the specific test? What is the specific piece of information? Is it user friendly? Can we do it? Does it lead to confusion or to enlightenment for the patient? Now, that's, sort of a difficult set of issues. And once you have information, you haven't solved the problem. You've only gone the first step. And then you got to get treatment, you got to get medication, you got to get a response. And, that kind of thing has also got to be there. There's got to be an infrastructure to respond. Pregnancy test, terrific infrastructure. Once you knew, you could push the right button, you could get an OBGYN, you could get the kinds of ultrasound, tests and all the genetic tests and all that stuff that you might need. But if you don't have that infrastructure, if you don't have that behind you at a reasonable cost, well, I don't know, if technology on its own is going to be able to solve those sorts of problems.
Well, and I think that's the fear of the doctors that I talk to is, okay, well, we give them the information, but now am I liable for it? Right? Like
Yeah.
the medical
Yeah.
malpractice and liability has made them afraid to experiment because they're not. And to be honest, maybe you know this better than I. I think they look at the law and they say it's not clear what my liability will be if they have this information and if they share this information, and am I liable because they shared it with me and I didn't address it? So we've almost created, because of medical malpractice, this culture of fear that doesn't allow them, or that's harder for them to embrace these types of patient empowering technologies.
I understand that anxiety, but it's quite an odd psychological barrier that doctors have created in their own culture. My
Mhm.
co-author, Michael Sachs, has described doctors' reaction to medical malpractice suits as something like the mouse that's perceived to have an otherworldly roar. There ain't
Interesting.
no real suits. There ain't no real recovery. There ain't no big catastrophe on this score. I mean, doctors face it maybe one time in their career, a thing. And it's a terrible experience. I have
It is.
actually been a litigant as well as a lawyer, and I didn't like being a litigant. So I can understand why a doctor might not either. And I know a heck of a lot more than they would. But it's a crazy kind of overreaction.
Mm.
And there's no real sound understanding that MedMal does not reach very far, does not reach very many people. And what we've done, and this is the doctors, the victim, we have made doctors the folks who hold the bag. That rather than the hospitals or the healthcare plans or the big overarching organizations that organize, pay for, and direct healthcare, we're blaming the individual doc, the wrong person, not the right place to focus. Let's say the hospital should be responsible. Let's say the healthcare entity should be responsible. They have the funds, they have the expertise to figure out where the problems are. And you have an error and it hurts somebody, well, they should take care of that. And it shouldn't be the doc whose life is undermined. She shouldn't have, a catastrophe because of a lawsuit, which is very rare, but there are some. It's got to be changed. But if we go back to something I said earlier, that tradition of independence in the
Yeah.
medical profession from 1890, 1900, 1910 on has made the doctors the victim of their own ideas, of their own rhetoric, has made them say, oh, we're going to be the ones who, are now holding the bag.
Uh,
Doesn't make sense. I mean, we're moving towards 50% or more of doctors being salaried individuals. Now, it should be the employer who's on whose watch harm is done, who should be responsible. So we've sort of, we're the prisoners of an old history, of an
sure.
old approach. And doctors, especially now in these times, in times of this pandemic, have been brave and public servants of the first order. And we ought to really say it's been remarkable what they've
Mhm.
done. And they've done it in the face of terrible political stupidity and resistance and, sort of changing technology and all the rest of that stuff. But gosh, they have created a system that in this regard, the med-mal regard, they have not understood and have made themselves the vulnerable parties when it shouldn't be that way. The reform should be have the enterprises pay,
Yeah.
have the enterprises have the responsibility to make it better and safer. That's going to
Yeah.
get you somewhere.
I mean, what a brilliant insight. So let's shift gears to telehealth for a bit. We obviously saw telehealth just explode, forced upon us by COVID in
Yeah.
many ways. And, it presents all sorts of new legal questions and challenges. So what's your perspective on what are some of the new legal and medical malpractice challenges that telehealth presents?
Well, let's start with the pluses. I think, that, you've already pointed out that COVID forced us kicking and screaming into a situation where we really recognized that telehealth was valuable. And it's valuable because it makes access to healthcare and advice much, much easier for a whole range of folks, especially those with very limited means. That's a really important public health step that, is really very valuable. Now, having said that, you have the other side of the coin. And, it seems like we've said that with respect to pharmacological, with respect to, all the other stuff we've talked about as well. But, now a single piece of advice, unfollowed up, sort of analyzed, unscrutinized, unchecked upon, can create really dangerous situations for the consumers. That if no one's keeping careful records, if no one's concerned about what the test results are or whether the test results were gotten, and if no one is following the patient, if there's no relationship in some sense, then you've got the vulnerability to mistake, to misdiagnosis. Now, doctors are highly trained and can be just super at analyzing illness, but often it takes some time. Now, one phone call may get you strep throat, but it may not get you pancreatic cancer. And, you're going to have the possibilities that you're going to be facing both sorts of things. Now, you've got to be able to say, hey, at some point, we've got to dig deeper. And it's there that the questions are the most challenging from a lawyer's perspective. What's the amount of digging that we have to anticipate is going to be required? And that's a challenge. And boy, as far as I'm concerned, I don't think we've settled that question at all.
Well, and some of this goes back to your previous comments about the organization should take some responsibility, especially when you look at the future of telehealth. Knowing when to use telehealth and when not to is going to become the responsibility in most cases of the organization, of the provider organization, and probably some technology bot, call center or whatever, that's going to decide this visit needs a telehealth visit, this visit needs a in-person visit. And so it's interesting, are the doctors going to be on the hook? Like you said, we're responsible, for that decision, even though the organization is making it. So it kind of ties in that previous one too, as far as when should I do telehealth, when not. Certainly the doctors are, and providers are going to give feedback to the organization of what's appropriate and what's not. But at the end of the day, that organization is going to make that decision, and the doctor is going to be faced, hey, you're here for telehealth, and I would have rather you had in person. That's a hard, challenging position to be in, right?
I agree. I mean, I think that is a tough position. I think especially as you get towards the entrepreneurial edges of telehealth, where you have private investors who are hiring, whoever they can find who has an MD somewhere and putting them out for single calls that are, sort of charged at some very substantial level. You're creating real danger to the public. And the people standing behind this are not healthcare deliverers, they're investors. Now, something that popped into my head, which may seem outrageous, is a little bit like those pornography 900 numbers. You call, you talk to someone, they charge you a lot of money, and then they disappear. They're invisible. They just want your money if they can get you on the line. Now, that's not good healthcare. That's not appropriate. It can be appropriate to have a single contact, especially if it's something like strep throat or that kind of thing. But boy, I'll tell you, as we move further down the line, you get to the places where we ought to be concerned about the delivery of care, about the quality of follow-up, about the quality of records, and the interaction between the online or on-phone communications and the follow-up that may happen in some particular medical practice. And all of that seems to me to be areas we have not thought about nearly carefully enough yet.
Yeah, there's a lot of risk in those direct-to-consumer pharmacy telehealth solutions, and ironically, a lot of them are that blue pill. Well, so your number's not far off.
But go back one step further. I mean, where did we really learn that this was a problem? It was with the online pharmacies distributing opioids. That's where it really began. That's where Congress actually legislated. And I may sound a bit like a broken record about opioids, but that was where it was, let's make a buck. Let's give people what they want. And let's not worry about care or about the vulnerabilities that the folks contacting us may have. And,
Yeah.
Congress eventually stopped that. But boy, that was a mess. And yeah, I mean, sort of Cialis and the rest of it has triggered that same thing more recently, although those may not be as harmful. I just don't know the data, so I can't say.
Yeah. That is the question. It may not be, but we'll see what the harm is from those, right? Anyway, there's a lot of interesting questions in that model as well. But in the title of your book, you talk about the legal innovations to, and this is just a powerful phrase, to end the epidemic of healthcare harm. What is the path to really do that, to end the epidemic of medical harm? What's needed? What can move us forward?
Well, it's a terrific question, and there's no single easy answer. There's no magic bullet
If it
here.
was easy, we would have done it.
Well, I hope we would have. I mean, you never can tell, but I think it's going to be a number of different things. One of them has got to be incentives. That the incentives have got to be for compensation only for care that is within the accepted standard of care. That when you step outside of that, and of course, Medicare, Medicaid have started to do this, private insurance has started to do this, but we certainly need a whole lot more. That you need that kind of incentive system. That's the American way, and it can be a very powerfully positive way. So you've got that. But second, I think you need something that we haven't had enough of, and that's careful surveillance. Now, you can't surveil everything, and we don't want the government surveilling everything. But New York, many decades ago, went through a time when it regulated cardiovascular surgery, where you were changing the veins around the heart because they were clogged or whatever. And what they did was they said, if you want to do that kind of surgery in this state, you have got to report to us your success rate, your mortality rate, your complication rate, and all that stuff. And we're going to track all of that stuff. And if we think you're an outlier, we're going to tell you, clean up your act or we're going to shut you down. And they started to actually do that. But then there was a second step. And this was the more interesting one. And that was that people in the press, people in, sort of the public information business said, hey, wait a minute, we want to know which hospitals are good and which ones are bad. And they sued, and the court said, this is a matter of public interest. And they disclosed the hospitals. Not only that, they disclosed the individual doctors. You know what happened in New York with respect to that CABG surgery? New York became the safest place in the country with respect to performing that kind of surgery. Now, it wasn't without some flaws. I mean, there's some criticism that people went elsewhere because, doctors were afraid to treat the worst cases and all that kind of thing. The data don't really support that very well. But, sort of the main point, if it's a serious surgery, if it's a profit center, which this was, government surveillance and government insistence on a level of care that is high quality can make a huge difference. Not everything. You got to pick your shots with respect to this. But, that too is a powerful lesson. Technology, we've talked about it. And it seems to me we put more in the hands of the patient, and the patient is going to be a better informed decision maker. She's going to be better at following up on the advice that her doctor gives her. And all of that stuff is going to be a real positive that, we should believe in empowering patients. And technology is a way that we can do that. But it's got to be user-friendly technology. It's got to be open to our understanding. I took a COVID test several months ago, which was done with my cell phone and a little test kit that I had at home. Damn, it was so well done. It was so terrific. And then the data were sent to a central processing system, came back and said, no, you don't have COVID. And, it was highly accurate. It was easy to do. And it proved to me that, writing as I have, yeah, you can make care a lot more effective, but you got to think about the interface. And that interface has got to be reliable, and it's got to be understandable, and all that kind of stuff. But all of those seem to me to be parts of this response. I mean, the other parts, I think, if doctors could get to the place where they felt more comfortable about saying, enterprise, you should be the one paying for these mistakes. That it's your job to worry about that stuff and to give us good guidelines, good support, all that kind of thing. I think that's going to be tremendously helpful if we ever get there. But we've got to understand that we're not there now. We're not even close. 400,000 folks are dying a year, and that's just way too many. That's your parents, that's my parents, that's your children, it's my children. And it's Neil Armstrong, first guy to walk on the moon, dies in a situation that looks pretty clearly like medical error, goes to the wrong hospital, a little hospital, goes to a place where they don't do many of the surgeries that he had to put in a pacemaker. And, they screw up taking out the electrodes, and the poor guy dies. This is the first man in human history to have done something amazing in a technological sense. And to have his life taken away by medical error just seems like, it could happen to any one of us. And we shouldn't be there. We don't need to be anymore. And we've got to decide that we really don't want to be.
Yeah. Well, I'm glad you brought up the element of kind of accountability and technology. I was talking to you about the technology and asking you, the first thought that came to my head was technology can help with better accountability, because you'll have more data to understand what happened and where the error happened and occurred. So that's one of my hopes for technology. And we talk about this a lot in the tech space, right? And we know the challenge of medical harm, and technology can help and hinder it. So hearing this from a legal perspective and medical malpractice perspective was really interesting. Thanks so much for taking the time to share about it. And of course, everyone should go download your book. I think we download it now rather than order. I mean, if you can order a copy, I'm sure too.
It's okay. I mean, if you download it, I don't know if you get to see the really spiffy cover. So
they're going to miss out.
Here it is with the the medical implement left inside.
Yeah.
But,
I remember.
One thing I haven't said, I just want to add,
go ahead.
is the technology, as you say, is going to generate a great deal of data. And if we look at those data in honest ways, and if we, sort of get good, clean, sensible data, we can do a lot to improve. We can see where the problems are. And that's something that only technology can really bring us effectively.
Awesome. Well, thanks so much for spending time with us. And thanks everyone for watching. If you want to find more great healthcare IT content like this, be sure to check it out at healthcareittoday.com. Thanks, Stephan.
Thank you, John. I appreciate it.